So, despite my lack of concern, thanks, John, about time, we seem to be a full hour behind, so we'll try and do a little catch-up here. Dr. Anik Wang's joining me on the panel here to lead us through, which is actually the first debate. We mislabeled the stuff, but on the issue of local therapy for EGFR-mutated lung cancer. So I don't know if you want to...
Yes. With the presentation of Laura at ASCO, this will be a very interesting hot topic. Our first presenter, we invite Dr. Wenzhao Zhang from Guangdao Provincial People's Hospital in China to present on surgery is the preferred option whenever feasible.
Well, thank you for the introduction. And my topic is for locally advanced non-small cell lung cancer with EGFR mutation, surgery is a preferred option. And the goal of the surgeon is the RCO resection and the ctDNA clearance, I think. Here's my disclosure. And cancer is an evolving organism, and the rationale of local therapy is the tumor heterogeneity, which will develop inevitably after the TKI treatment. And this lists the many mechanisms of the TKI acquired resistance. And traditionally, more strategy, including the combination of the drug A and drug B and sequential drug A and drug B to aim at the activation pathway. And actually, the local therapy is very important to overcome the heterogeneity. And multiple perspective clinical trial has focused on the oligometastasis, mainly with the TKI treatment, to explore the role of the local treatment in the prognostics, and they find that the local treatment, including the surgical base and radiation base, can improve the progression-free survival and even some overall survival. And we can see this case as a female, a non-smoker, and very great mass located and right lower lobe, and stage 3 non-small cell adenocarcinoma. And the genetic profile shows that the EGFR activating exon 19 deletion and the MET and concurrent with the MET skipping mutation, and the TPS is 30%. And what's the treatment strategy for these kinds of stage 3 patients? Oh, okay. I think there's several strategies, including the ADORA model, and including the RORA model, and also including the neoadjuvant treatment strategy. Actually, the stage 3 non-small cell lung cancer is a very highly heterogeneous population. The stage 3A12 is the accidental lymph node metastasis in the pathology proven and intraoperative. And stage 3A is the single or multiple lymph node metastasis with potential resectable, and 3A4 is the bulky lymph node and the fixed lymph node. And it determines the selection bias in the treatment strategy between the medical oncology, radiation oncology, and the thoracic surgeon. And there are about globally 10 guidelines focused on the stage 3A and 2 non-small cell lung cancer. The flow chart includes firstly differentiate resectable and unresectable, single station, multiple station, and multiple station, and the patient should select the surgical base and radiation base. Actually, they're very controversial between these guidelines. And we also see the target enrollment population of the 3 trials, including the ADORA study, mainly enrolling the resectable patient, early stage. And the new ADORA study may enroll part of the potential resectable patient. And the RORA study enrolling the unresectable patient, and I think some potential resectable patient, because the definition of resectable is not very clear based on the URCT guideline. They said what is the multiple station is determined case by case, and And also the short S, the lymph node is different between the different guidelines. Some is the 2 centimeter with multiple stations. Some is one station larger than 3 centimeter, and this guideline is 2.5% to 3%. And I think the 3 randomized control trials have overlap. Firstly, the standard of care of this stage 3 based on the ADORA study and the ROLA study. ADORA study is a surgical-based randomized control trial in the subset of the stage 3A. The 5-year overall survival is 85%. And the ROLA study is a radiation-based randomized control trial. And we can see that the progression-free survival of the 2 studies in the subset of the stage 3A is very similar, 40 months. But the contribution of the concurrent CRT is very limited. In the placebo arm, just 5.6 months, and the survival curve sharp certainly. And we also have several problems to be solved, including just 40% of patients can finish the CRT and can be randomized, and part of patients have severe side effect and no significant difference between the OS. And we also have a comparison between the ctDNA clearance between the different style of local therapy. It seems that after the surgery, the ctDNA clearance is superior than the CRT. The ctDNA clearance is 64%, and the local radiation is 22%. And traditionally, the definition of axial resection is based on the anatomy. Actually, the biological axial resection should consider the ctDNA clearance. And from the consolidation to neoadjuvant therapy, we have the role of the downstaging and irradiate the MRD, and have also predict the next steps systemic therapy. And we also, with the surgical tissue sample, have the comprehensive pathologic evaluation and genetic profile to make a decision after the surgery. And CTON-1103 is the first randomized control trial evaluating the role of the neoadjuvant first generation TKI. Enroll the potential resectable and unresectable stage 3 non-small cell lung cancer with EGFR mutation, and the control arm is the gemcitabine cisplatin for 2 cycles. And at that time, the primary endpoint is the objective response rate is a boundary improve the objective response rate. And it also found that the first generation of TKI have the limited MPR, just 9.7%, and the PCR is 0. And several phase 2 single-arm clinical trial proved that the MPR in the third generation of TKI is also limited. MPR is 15%. We are also looking for the new ADORA, the result. Besides the EGFR pathway, the ALK pathway is more aggressive and easy to develop to locally advanced. We have a cohort study comparing the alectinib with crizotinib in the induction therapy for the ALK positive non-small cell lung cancer. And we found that after the 90 days of the induction alectinib therapy, the PCR is 35% and the MPR is 64%. And in this article, there's also a pool analysis in the positive stage 3 retrospective trial, just like the Horizon 1. And we see that the induction therapy surgery-based model is very similar to the radiation model, no matter in the progression-free survival and overall survival. And as we see that in this morning's, the radiation, the technique is improved very quickly. And also in the setting of the neoadjuvant therapy for locally advanced, the robot surgery can have a very bulky lymph node arterial resection and sleeve resection and angioplasty resection and have a good result. And we also noticed that no matter in the Pacific study and the Royal study, very limited thoracic surgeons have evaluated acceptable for the patient. And we think that the clinical trial design should enrolling multidisciplinary therapy. Here we have initially approach study, CTON study that enrolling the stage 3 non-small cell lung cancer unresectable stage 3 non-small cell lung cancer with EGFR mutation. And after 8 weeks of the third generation of TKI, and we will have a multidisciplinary discussion for local therapy, radiotherapy or surgery. And then after the local therapy, we'll randomize to the third generation of consolidation therapy until the progression disease or the MRD guide therapy. The primary endpoint is the ORR and the EFS. And the second study design is the sequential TKI and IO chemo in the EGFR mutation non-small cell lung cancer with the stage 3A. We also have a questionnaire about the preferred option of the circle-based and radiation-based. Totally, there are 151 physicians have attended the questionnaire, and we found that 50 physicians choose the surgical-based and 30 physicians choose the radiation-based. And it also have the selection by biopsy. The subgroup analysis showed that the medical oncology and the thoracic surgeon are the surgical-based, and the radiation oncology will choose the radiation-based. And back to the previous case, the stage 3 non-small cell lung cancer with the EGFR activating mutation and MET skipping. I think the dollar is not suitable because the patient have the physio has invasive and not reach arterial resection. And a lot of study and the new adjuvant study, I will choose the new adjuvant study to have downstaging and arterial resection and base the tissue sample and guide the next consolidation therapy. Thank you for attention.